Hello, I'm Dr. Marla Shapiro. I'm a former president of the North American Menopause Society, and I sit on the board of trustees, and I'm joined by a former president of the North American Menopause Society as well, Dr. Pauline Mackey. Please tell us who you are and what you do.
So I'm Pauline Mackey, professor of psychiatry, psychology, and obstetrics and gynecology at the University of Illinois at Chicago, and I study the psychological and cognitive effects of the menopause.
So let's talk about women in the perimenopause and menopause and depression. Is it different, and do we need guidelines to help us navigate this for women?
Perimenopausal depression is different from depression at other times of life in that the symptoms of the menopause itself can overlap, co-occur, or complicate the symptoms of depression. So to make that very concrete, one of the symptoms of depression is poor sleep. What happens to women as they transition through the menopause? Their sleep becomes disrupted. So one has to be very careful in attributing sleep disruption at this time in life to depression versus the menopausal transition.
So what is key for physicians to know, healthcare providers, all healthcare providers to know in terms of trying to assess whether the woman that's sitting in front of them is sad or has a clinical depression?
This is a key question. One important thing to do is to raise awareness of the need to assess. So why should providers assess depression in perimenopausal women? It turns out that large longitudinal studies show that the majority of women, that is 58% of women with a history of depression, experience a recurrence of depression during the menopausal transition. So the most important person for providers to screen are women with a history of depression, because the majority will experience a recurrence during the menopausal transition.
And is this a vulnerable period?
It is a vulnerable period. Just like the perinatal period is a period of vulnerability for women. So during pregnancy and the postpartum, there's an increased risk of depressive symptoms and major depressive disorder. The menopausal transition is another example of these hormonal stages in a woman's life where she becomes more vulnerable to mood disruption.
So how to screen these women?
So the most concrete thing to do is to take a standard diagnostic screener. The easiest one would be the PHQ-2, which asks two general symptoms. Are you experiencing a decreased interest in things that typically give you pleasure? That's one. Anhedonia is the name of that symptom. And the second one is the standard, are you feeling down or blue? And if a woman says no to both of those, practice says in general you don't need to move on any further.
So for that woman that then says, I'm having trouble sleeping, that you think of now is more related to the transition itself and hormones as opposed to mood.
Exactly. Yeah, so beginning with the cardinal symptoms of depression and determining whether you need to ask further questions, that's a very good practical approach for the provider. That being said, if a provider does know that a woman has a history of depression, and let's remember, depression is twice as frequent in men than in women, then it's important to do a full screen and actually have an active conversation with the patient about, you need to know that this is a window of vulnerability for you.
When does a healthcare provider decide it's time to jump in with therapy, meaning medication?
When the symptoms affect a woman and decrease her ability to function in her everyday life for 2 or more weeks. So the symptoms have to have this functional effect. They have to decrease her ability to perform in her home life, in her work life, in her social life. That suggests the need for intervention. Again, using these standardized assessments to screen for depression can very much help.
In terms of having these guidelines, does it highlight to healthcare providers that really you need to be thinking about this?
That's the point. What's very interesting and what's wonderful is that society now understands that there's something called perinatal depression. And indeed, there are policies in place to encourage providers to screen for this. Now, perinatal depression affects maybe 17 to 20% of women. The menopausal depression that we're seeing in the large prospective studies affects 28% of women with no history of depression and 58% of women with depression. So it would be good to give
Big
the
numbers.
two big numbers.
Big numbers. So although the women who have had a previous history of depression really do have a red flag, these are women you cannot afford not to screen, is the message that all perimenopausal women should be asked these questions to tease out what some of them think are aging, menopause, can't do anything about it, without recognizing that it may be something more severe?
Yes, yes, exactly. That's exactly the case. And also recognizing the importance of the cardinal symptom of menopause, vasomotor symptoms. What happens when they happen at night? It disrupts sleep. What happens when sleep is chronically disrupted? It affects our mood. And it can lead to elevated depressive symptoms that don't quite meet the criteria for major depressive disorders, but which nevertheless are immensely disruptive to a woman's life. So that's the difference between this elevation in depressive symptoms versus the onset of a depressive disorder. Both need to be attended to. And in that case that I just described, where we think that it's this cascade of events that's leading to the mood disruption, that's when you begin to think of menopausal symptoms and the need to treat those symptoms.
And to be able to give, I think, a woman insight that these symptoms really do need to be treated, because so many women are fearful of treating these symptoms that we've often seen now a decline in the use of menopausal hormone therapy and an increase in some of the antidepressants. Can you comment on that?
So the guidelines that we created indicate that the first line of therapy is an antidepressant or cognitive behavior therapy. Both are evidence-based treatments. Now, I might say that if the flavor of the depression is one where it's life changes, marital changes, coming to terms with aging, cognitive behavior therapy is the way to go, because the antidepressant medication doesn't necessarily change the way a woman thinks about those. If, however, it seems to be more, if you will, biological, it's the sleep disruption, it's the lack of energy, then one might go for an antidepressant, or perhaps both. Right? So we want to tailor the treatment to the particular aspects of a woman's life that are giving rise to the symptoms.
And is there a time where a physician will do the screening and realize that really most of this is based or starts with the menopausal hot flash, night sweat, insomnia, mood change, and guide a patient to deal with that underlying root cause in terms of dealing with the hot flashes and night sweats?
Yes, and particularly in the perimenopausal period, where we have pretty good data to show that estrogen treatment prevents both remission, or prevents recurrence of depression, promotes remission of depression, and also improves depressive symptoms. That's specifically for the perimenopause. Postmenopausally, estrogen therapy doesn't seem to do much good.
Thank you so much. I think this is so critical for healthcare providers to realize this is yet one more thing that we must screen for, in addition to all the other things that we worry about, blood pressure, cholesterol. This is as critical for us to be aware.
Yes.
Thank you.
Thank you.